switch this. Okay. Just confirming, Len, you see my slides in full form, right?
Yes.
Okay. Good morning, everyone. My name is John Lynch. As Len mentioned, I'm an infectious diseases doctor. I don't know how many years I've been doing this, but I have a number of years ago I started tracking some of the topics. Before I get into it, I don't have any disclosures pertinent to this talk, but over the last year, I've worked with the NFL, Alaska Airlines, the Port of Seattle, Vertical World, and NFL on COVID prevention. I wrote NFL twice, sorry. Just going back quickly, I just thought this was kind of interesting. I started telling folks what I had talked about the year before, back in 2016, although I started talking about it. I started talking to this group, I think a few years before that. I just mentioned Zika virus in 2016, Zika virus, influenza, Ebola virus, 2017, Candida auris, a highly drug-resistant Candida fungus in 2018, and drug resistance, 2019 measles outbreak, 2020. I don't think I gave you a talk last year. I actually don't remember, but I couldn't find anything in my files. So that brings us to 2021, and I thought this would be a little bit different. My last year has been occupied with one thing and one thing only, and that's COVID-19. So today, I'm going to be talking about a COVID perspective, probably unsurprisingly. Hopefully this isn't a rehash of things people have heard before. And just to give you a sense of what it was like to work on the COVID response from patient number one, at least in North America, to what I think now is over 31 million people, which is kind of crazy to say. Just a quick highlight here. This comes from a KUOW NPR article that I thought was really helpful in thinking about how we as humans and human populations respond to disasters. And so this one is set up as an outbreak. You can see we have a pre-disaster timing where there's a warning and threat for those of us in infectious diseases. That was back in kind of December of last year. And then an outbreak, an impact. And I would say for us in Western Washington and probably Washington State was that patient diagnosed at Prov Everett, which I'll talk about, a humongous response with a lot of community cohesion. And then a period of disillusionment, which I would argue we are still deep into with various trigger reactions, with improvements and worsening of the pandemic over time. Anniversary reactions. We just, it's now been a couple of months moving through a lot of those 1 year sort of, I don't know, the right term is celebration. And then reconstruction, working through grief, coming to terms, setbacks, and so forth. And as we work through what I would say is our fourth wave, at the same time, they're getting access to vaccines and struggling with some of those, such as the new announcement this morning that J&J hold, really kind of working through how do we move back to some new beginning. And so I'm going to just think about this as I talk a little bit through my experience. So as I mentioned, Harborview and UW Medicine has been preparing for serious pandemic-like outbreaks for a number of years. This is our Ebola we're part of a national Ebola consortium that works on response. This is from stuff in the past. We responded to the 2014 and actually even the recent Ebola outbreak in West Africa, being prepared and working with public health to respond to the care of folks with Ebola. But I think this really set us up in many ways for dealing with other, obviously, pandemics, which is, I think, part of the point. That in the lower left-hand corner, you see my partner here at Harborview, Vanessa McCarowitz, an amazing nurse leader who's led all of this work from the PPE to protocols, to bedside support throughout all of it. Without her, none of this could have been done.
Hey, John, a couple of people have chatted here. They're only seeing a part of your slides. They're not centered. I don't know if you can really do
okay,
anything.
let me just let me end this, and I'll just, sometimes I have to stop it and reshare it. So I'll do that again. Sorry about that.
Also, do you know the word of the day? People have asked me that already.
Infection. Big surprise.
All right.
I think it's on the last slide. How's that look now? Is that any better?
Well, so far that looks fine to me. We'll move along and we'll see.
Okay.
We're still seeing only a part of the slides.
How
Well,
weird.
now I think it's better.
That's odd. I've never had that problem before.
I mean, you can see, I can see at least 90% of it. I don't think it's worth stopping.
Okay. I apologize, folks. I don't know what's going on.
Yeah, I think it's better now.
Okay. Yeah. So this is from sort of our initiation, from sort of this background preparation for lots of things, including Ebola and other pandemic type diseases. This is going back to January 2020, when our infection prevention and control team here at Harborview sent out this outbreak situation report to sort of raise awareness. Basically, at this point, a description of pneumonia in China, 59 cases of unknown viral pneumonia reported in central China, in an area that I wasn't familiar with, but now know, Wuhan and Hubei province know extremely well. You can see the bottom right. This is the WHO Twitter feed from January 4th. China has reported a cluster of pneumonia cases with no deaths in Wuhan in the Hubei province. And you see later, closely watching to see what's going on. So that was sort of our warning when you look at that pattern I showed you earlier. This is from Vanessa's phone, January 21st, 2020. So a couple weeks later. Hey, did you hear about a Prov Everett has a rule out case, referred to a COVID case? No, and then started texting. And we have a great situation here in Harborview and within Washington State with that NETAC, that Ebola consortium group, where a lot of the leaders know each other and can comment. So this was a shared conversation with the Vanessa's role out in Spokane and about these rumors. And so it started a text chain here with Krista out in Spokane. Hey, our CMO emailed me this morning, say they're activating the unit. This will be our first case. This is happening so fast. Really, was amazingly quick once it started happening. Here's, I think the next day, if we needed to transfer, how much time do you think it would take? I'm the dentist. Is this a hypothetical question? This is the infection prevention stuff at Prov Everett on 122. And that was really the conversations are going on around the fact that this case in Snohomish was diagnosed of a Prov Everett. So this is a man who had returned from Hubei province, Wuhan, back in January. He spent a few days walking around, developed some symptoms, had heard about this concern and self-identified to clinicians, got tested as an outpatient, was found to be positive, the first positive case in North America. I think at that point, actually in the Western Hemisphere, and was hospitalized, developed symptoms, required some oxygen support and fairly lengthy hospitalization. But one of the key things we recognized very early on was the level of concern. So you can see the governor, Secretary Weissman, and Dr. Pillai from the CDC with this one single case and their response. But one of the big things was that this individual had been around in the community and had been around somewhere between 50 and 70 other people, both in Snohomish and King County. And basically within a couple of days, we learned that public health was, due to decades of poor resource allocation by our government, was really incapable of doing the level of investigation and tracking that needed to be done for this one single case of COVID-19 in our community. You can see just a quick snapshot of the way things looked on 122. You can see there were about 549 cases in China, 104 in other Asian countries, and then one case in the United States in the Western Hemisphere, and that was right here in Western Washington. At that point, we had about 16 healthcare workers and about 17 deaths. And that's where, my team here and myself really started our intense journey. What we recognized, because public health couldn't do all of the things that needed to happen for these exposed people, that they contacted partners for help. And one of them was us. We had established as part of that Ebola preparation what was called a home assessment team, where we would send out a team of 4 to 5 individuals, including a physician and a nurse in PPE, and be able to do assessments in people's homes or hotels, do testing there, and bring those tests back to labs. And being in the middle of the respiratory virus season, we're having a lot of people in that exposed population who needed to be tested. And so in an effort to keep people out of the hospital and potentially increase risk for healthcare workers and other people, public health reached out to us to help them and reactivate this home assessment team. So there's Vanessa in the middle, Chloe Bryson Khan, another partner here. And you can see how we would set up in these different hotels, high rises, homes, driveways, garages to do this work in an effort to do these investigations. And you can see that we had a lot of great response very early on. So we had an unknown infectious disease. We knew it was a virus, a respiratory virus. When we asked for help, people would say, "Hey, can I volunteer?" And they would say, "Why?" And I'm like, "That's my job." It was really quite an amazing thing to be part of. We did publish on it. There's a citation on this novel approach for a novel pathogen, which was pretty cool. So that was our kickoff, was spending nights and weekends responding to symptomatic folks who were exposed. This is just to give you a sense of how involved it was. We have a lot of checkoffs, sort of like a plane taking off. How do you get into a space? How do you leave a space? How do you handle all of the trash? You can see, this is a garage, how it looks like, with a hot zone, a warm zone, a cold zone, a whole manual on how to do this work. And so we got pretty deep in the weeds on this extremely early, and in many ways set us up for some success as a result, because we were able to take a lot of these home assessment team protocols and turn them into hospital protocols going forward. So this is from Aaron Resnick, who's one of the leaders in Northwest Healthcare Response Network, which helps with that response in Western Washington. And we heard about a lady in our emergency department. This was just days later on January 29th. So this is a text from Vanessa, was finishing up a home visit, got the call. We have a person in our ED, our SPAT team, which is our special pathogens team, which grew out of that NETEC work. You can just see the support. Hey, good luck. You're all pros. I think both of these are legit. So really moving into game time. So between that first diagnosis, the 20th, to 9 days later, having people in our emergency department. And that's me on the left. You can see a lot of members of our teams, our leadership, Rick Goss, engineering in the back, Mike Warren, nurses, hospitalists, all getting ready to work with a patient who's in the room directly behind me in terms of PPE, just sort of rallying the troops with our first in ED patient or potential rule out. We started working, through all the different protocols, trying to figure out, how does EMS handle this? How do we move patients from EMS and elsewhere? And that's a picture that Vanessa took of me on February 5th, where we quickly realized that the response was going to be incredibly fragmented early on, because again, we as a community, as our government, and this is true across the United States, have sorely, woefully, poorly resourced public health. And our public health colleagues quickly realized that they did not have enough people to do the work that they so desperately wanted to do and were trained to do. And it was just sort of a moment of realization that a lot of this was going to have to be figured out on the fly and on our own, that there was no help coming, no rescue to show us what to do. So a lot happened in the next couple of weeks, as we all know. This is through the beginning of February. We started seeing, folks in our emergency department try to figure out policies and procedures, training new people, greatly expanding the pool of people who could wear the appropriate PPE, not knowing how this virus actually moved around, what was the level of PPE that was needed. Working with public health on, this was the form on the left, was how every single person who was exposed originally got the data collected. You can just imagine how impossible that would be at this time. But that was the thinking at that point. Rare cases, exposures, getting tons of details on those folks and isolating them in terms of their travel exposure and so forth. Really quite amazing to think about where we've come from to where we are now. So February 19th, middle of February, you can see that at that point in the United States, we had about 479 folks who are under investigation, 15 positive. In Washington State, about 26 folks had been tested. Most were negative, a couple pending. And you can see approaching 800 people in the United States who are under quarantine. And again, just to give you a context of where we are now to where we were when we started rolling up. So last week of February, this is when things really changed for, I think, everyone on this call. So on February 25th, thanks to the heroic action of the Seattle flu studying Dr. Helen Chu, we learned about the first community case of COVID-19. This was a teenager in North Seattle who was diagnosed after developing a febrile syndrome for several days, got tested, and then finally was part of the Seattle flu study. And Dr. Chu and her team decided to start testing those at-home flu swabs for SARS-CoV-2 and made that diagnosis and basically demonstrated that there was community transmission that was ongoing. On February 26th, we learned this retrospectively. We had a patient from a skilled nursing facility, which I'll talk about in a moment, who had actually been hospitalized with sepsis, was moved to comfort care and died in our ICU before we had any precautions in place for COVID-19. And we found out again retrospectively had COVID. 28 February, a handful of patients were admitted up to Evergreen and ended up testing positive for SARS-CoV-2. That was a Friday. And then on Saturday, our home assessment team went out to do testing of that community case to see whether we could clear him, whether his family had been infected. I left that morning thinking, let's get this HAT team visit done early in the morning and have the rest of Saturday. I think I got home about 1 a.m. because we then learned that Valley Medical Center had a hospitalization in a patient who had been there for about a week and was diagnosed and had a huge exposure as a result. The next morning, Sunday, we realized that we had that death. So we had our exposure here at Harborview, and as a result, activated our emergency operations center within UW Medicine and all of our hospitals. And thanks to the forward thinking of Doctors Alex Gredinger and Keith Jerome and many others who had developed testing, PCR-based testing for COVID-19 back in January, recognizing that this type of platform was going to be desperately needed. We were able to start testing all respiratory virus or respiratory patients by the following Monday night and started in our ED. So everyone was being admitted, got tested for SARS-CoV-2 as a result of that forward thinking by that team. It's really quite amazing ability to change. But in that basically course of a week, we went from, no widespread COVID-19 epidemic to widespread engagement in responding to a pandemic. And that was probably my last normal week in the last probably year. I think we all know about the Life Care Center of Kirkland and the outbreak there, which was massive. Evergreen's response to this was heroic. Their team did an amazing amount of work, and I think a lot of the community responded to figure out ways to support them and to start moving patients around so they didn't get overwhelmed. This is March 2nd, so over the course of that weekend, second U.S. coronavirus death in King County, more cases likely. At this point, we didn't know the full extent of infections and deaths, at least in the western part of the United States. And you can see 2 of our infection prevention teams there featured on the front page carrying our home assessment work. Krista Rietberg is one of our infection preventionists on the right, and Monica Hofsmith is on the left. She's one of our nurses who was part of our HAT team. Because of that exposure, we needed to figure out how to do testing of people who were exposed. This is our first iteration of our testing. On the left-hand side, we took a conference room, put up these plastic barriers. There's another member of our team who would bring in people through a corridor in the back of that building on the right. They would follow that little sun balloon park, and then we would direct them into the hospital through a dedicated corridor, get into this conference room, get tested, and then be able to go back home. And this is our first iteration of employee exposure testing, which again was prescient because it's a huge part of our work over the last year. I don't know how many folks on the call have been involved in emergency operations, but we basically set up this incident command structure. And for physicians, it often feels a little odd. So we've been leading all this work, basically every day at around 4, we'd have a response meeting, figure out how to do screening at front desk and testing and so forth. And then when you set up an incident command structure, the folks who lead that process, these emergency operations center, they're not doctors, they're not nurses, they're folks who know how to make things happen, how to make organizations work in a fairly hierarchical way. This has come out of other disasters, but probably most importantly, the wilderness fire community, and they've really set up a structure that's used uniformly in North America, and honestly is being adopted throughout the world. That's really set up with an incident commander. This is not a subject matter expert. It's someone who knows how to run this system. And then we have operations team, planning team, logistics, finance administration in the simplest iteration. That incident commander gets additional information from safety teams, liaison teams, public information teams, and what's called medical technical teams. And that's what I ended up running, and has been working on developing policies and advising the incident command structure pretty much continuously. And you can imagine that with all these groups, and this is a simple chart of this, have been meeting on a daily basis since this whole thing started. We're really lucky in Washington State to have great organizations and relationships across our hospitals, across the public health groups, Department of Health, and the Northwest Healthcare Response Network. And we really leaned heavily on all these relationships as we move forward. We're able to get great partnerships, great open lines of communication as we handle this. And just one example is that we had this, technical response. We recognized that we couldn't afford as a state or Western Washington to lose any one hospital in a way that sort of Life Center went under. And so we basically developed through our emergency department and working across Northwest Healthcare Response Network, what was then called the Regional COVID Coordinating Center, or RC3. And this was an effort not to triage from disaster sites, which we did with the Life Center facility. How do you send out patients from that one facility to many facilities? But how do you triage from facilities to make sure that they weren't overwhelmed? So when Evergreen started getting incredibly busy, via ICU, ECMO needs, acute care, how do you move people from those places out to other hospitals? And that actually persisted and is developed into the Washington Medical Coordinating Committee, which now has a dashboard that was developed by Microsoft that all the hospitals put data into. So there's visibility and transparency about how many COVID patients in different parts of hospitals there are across the state and where we can move people. And this became incredibly valuable as we moved through the various waves last year, especially. This is our EOC. You can see pretty big organization. It's kind of strange to look back to see all these unmasked people in a group, but that's the way it was when we kicked this off. This is an article in the Wall Street Journal. There's Vanessa on the right, me on the left. A lot of time in this room working on policies, trying to figure out how stuff was going to go. It was really an all hands on response that was quite amazing to be part of. Very energizing, but all encompassing. These were, I think, as everyone can imagine, if you weren't involved, 15, 16, 17, 18-hour days in those first few months. This is the way things started before we had any electronic platforms. So this is looking at numbers, so Northwest, we had 9 pending, 16 positive, Jerry Psych Unit, UWMC, 3 ICU, 6 pending, 1 acute, Harborview, 7 positive, 3 pending. UWMC, how many tests yesterday, looking at what's happening at Airlift Northwest, where we are with PPE and so forth. We didn't have a system to do all this tracking. Medical record systems don't help you with this. So it was a lot of me writing on pieces of paper, calling people every day to try to get a sense of what things were like across our system. And I'm sure every other system was doing something similarly. It's also interesting to see 112 tests done. We were outstripping pretty much everyone else because of our access to the UW Clinical Virology Lab. But this was really, even with that access, we should have been doing thousands of tests a day. And again, even it was, looking back, how much that could have helped us. We also recognized that we needed to think about our PPE. How do we get people tested fast enough so that we can either put them in the right space with the right PPE or discontinue or de-escalate PPE? And we started, basically educating, our team started educating the rest of the EOC on things like burn rate and its relationship to supply chain, how testing people as fast as possible in the middle of flu season to rule out flu, RSV, and then maybe COVID-19 was going to impact things like how many N95s we had. And you can see on the right, what we all have heard so much about in terms of flattening the curve was really, trying to explain how we need to slow down transmission, how we had to manage a pandemic, the entry of a pandemic for which we had no treatment and no vaccine, was critical to sort of people's conceptualization of this as we go forward. You can see we're even looking at how fast can we get the swab from the nose to the courier to us and UW Medical and UW system down to South Lake Union to get tested in the virology lab. Like, how can we make that faster so we can de-escalate folks and steward our PP as best possible? This is just some snapshots of some of the first cases. On the right side is Dr. Mike Suter, an anesthesiologist, doing in-room intubation using a glide scope. You can see the level of PP he was using at that time. What do you do with a glide scope in someone you just intubated who has COVID-19? How do you use hemodialysis and ECMO, in these spaces? Was really all we needed to be figured out on the fly and written down so that we could learn from that activity and then make it a policy. This is our old 2S unit, which got turned, was a neurosciences ICU, got turned into our COVID ICU. You can see this is just March 19th, about 20 days later. You can see here's, so the nurse is responding. There's Nathan Napolitano, one of our infection prevention teams. We basically had someone on the unit 24 hours a day to make sure that people got their questions answered and were as safe as possible. We developed lots of policies and protocols, which I'm not going to go through. This gets pretty complex, and we recognize the need for people to help people through this process through what we're called trained observers, or maybe called officers where you are. There's no way a healthcare worker can remember all of these steps, sort of like I said, taking off in a plane or landing. And so we have to build a structure around healthcare workers going into COVID rooms through these trained officers so they can help people get into a space with the right PPE and get out of the space without contaminating themselves, which honestly was among the greatest risks that we recognized at the time. We started learning from other outbreaks in the world. This is from the terrible outbreak in Italy about how to take care of patients. Big concern about maybe potentially running out of ventilators back then, learning about things like proning, clinical pearls from our colleagues, but really seeing this as our future in Seattle and in Western Washington was incredibly sobering and pretty scary, to be honest. This is the outbreak in New York. You can see this is in Detroit. You can see the Henry Ford Health System had 280 patients as of Wednesday morning. By that afternoon, 304 with another 107 waiting for tests. You can see in the right bottom there, this is in Brooklyn, just the number of people dying. You can remember all the reports at that point. So again, just thinking about how this is going to roll out in our area was, trying to struggle with all of these different pieces. Do we need refrigerator trucks for bodies? Do we need more body bags? Do we need more ventilators? And all the complexities with all of those things. PPE became a huge issue. We quickly recognized we did not have enough N95s to use in the way that was sort of being recommended, sort of a maximalist approach to PPE. But our front line was trying to figure out really inventive and thoughtful ways to make this work. You can see there's a snapshot of someone using their, this is where they'd be reusing their N95 so it wouldn't get dirty. Here's someone hanging it off a straw in their paper bag. These are clean lunch containers where people could put them in there and then take their N95 out and reuse it. Really interesting and creative ways of thinking about how to, again, steward our PPE early on. This is an early test we were doing using UVC to expose used N95 so that if we needed to reuse them, they would be reprocessed. And again, we had a whole team working on sort of the technical aspects of that PPE reuse. We also had, as I mentioned, an incredible amount of teamwork. This is just a very snapshots. Left-hand side is our 2 West ICU. Right side, some nurses outside doing, I think, some media. Just to give you an example of just the amazingness of nurses. In our home assessment team, Vanessa would make us, she didn't want our scrubs dragging on the ground. So she would make us tuck our scrubs into our socks. And it was amazing. This was part of the home assessment team sort of protocol. And when we taught the folks in the ICU and acute care units, 2 West, 4 East here at Harborview, how to do it, they started really bringing some life to it. You can see all these nurses with various iterations of socks. This is a sticker one of them made, HMC 2020. You can see the socks tucked in over here. And there's actually, if you're interested, if you're an Instagram social media person, Katie Hammond actually has a COVID socks Instagram with all the different socks that people wear. And this is actually spread across the country with people sort of demonstrating their individuality, bringing a little bit of life and humanity to clinical care in the midst of all this terribleness. And this still continues to this day. You'll still see a lot of people walking around with their pants rolled up and their bright colored socks showing out. And you may see in other parts of the country as well. A lot happened for all of us very quickly after. We had a couple of emergency room docs who ended up getting COVID as part of their care, or maybe being in those communities, hard to know. And so that fear part really started building up. And then in the middle of March, public school, I think it was a Wednesday night in Seattle, said school's closed for 2 weeks starting tomorrow, which was incredibly disruptive for everyone in healthcare. You know, many people have children in school, and all of a sudden you lost your daycare during the day. And that was very sudden and crazy. We started seeing the impacts in the city with decrease in traffic. This is a snapshot on the right, looking down from Harborview and this heart in a window. You can start to see businesses getting boarded up, just the massive change that we've undergone over the last year. Back in the spring, we had our first case here at Harborview of someone who got COVID-19, likely as a part of work. That was Alex Volman. He was a burn nurse, an amazing person, who ended up recovering, and then a couple weeks after his recovery, died suddenly. It was our first death here at Harborview, and was really hard for all of us, I'm sure for anyone who experienced this. You know, it was really very hit our community really hard. And that sort of shared grief part was very difficult. And on the right, Katie Ellis, administrative specialist, who got COVID someplace else, don't know where, also passed away sort of suddenly. And so again, just recognizing that sort of hoorah attitude, and then the balance of the risks that healthcare workers are take, again, pretty big for the community. We had some successes. This is America's grandma, Geneva Wood, who was a life care center patient who got COVID, got sick, but actually recovered really well and ended up going home. She was a huge win for us. If ever Len can share these slides with anyone, but you can find her on YouTube talking about this. She made national news as this elder adult who, you know, was able to get through it and survive and leave the hospital intact and healthy. And, you know, you're balancing things like, you know, the deaths we saw in healthcare workers with these saves. And it really was quite an emotional roller coaster. And just to give you context, that was phase one. That was really the beginning of all of this. And you can see a huge amount happened subsequently for everyone on this call. You know, we finished out that spring surge with a plateau that in King County was around 25 cases per 100,000 over the prior 14 days. And we had a little bit of normalcy, a little bit of breathing there. Things loosened up a bit. School never restarted, but we moved into the summer and a lot of activity outdoors. And what we saw then was going from this outbreak, it was really, you know, dealing with older adults, a lot of comorbidities, to this summer surge, which was really mixed bag. A lot of younger people out and about trying to regain some sense of normalcy across the state. A lot of cases in Eastern Washington, which had been spared in that first phase, that then reflected back to Western Washington. And I'll just point out here is that after that summer surge, our plateau was around 50 cases. So we basically doubled our daily number of cases. So 50 cases per 100K over the prior 14 days in King County. And then we started seeing the fall surge, this huge surge. These bumps or these decreases here are really to do with decreased testing around different holidays. And then a steep drop now. And in King County, we never got below about 85 cases per 100K over the prior 14 days, and have since climbed quite a bit since I put these slides together. Just think about all those handwritten notes. We developed a huge amount of dashboards. Our information technology team started putting together and collecting data so they could track cases. This is COVID-19 hospitalizations and our spring surge, our summer surge, and then our winter surge. Just going out to the end of January, we since went down quite a bit and are starting to climb again. We're almost at 50 cases in UW Medicine hospitals, with the dark bars being ICU and the light bars being acute care. You can see admissions per day, and then discharges, and in red, deaths. And you can see through a large part of this pandemic, we were losing people to COVID-19 almost every single day within our system. The other thing I'd like to call out is the distribution of COVID-19 was not equitable. And this has been a truth in infectious diseases, and I think true for many other medical problems. But in ID, we know that infectious diseases are disproportionately impact different communities, particularly communities of color, socioeconomic categories is similar. And just to give you an example, this is a snapshot of COVID-19 cases, with the gray bars being the percent of King County population and the blue bars being percent of COVID-19 cases. And this has been true throughout the pandemic. So just to illustrate, in the top section here, people who identify as white are approximately 60% of King County residents, yet represent about 40% of cases. But if you look at folks who identify as Black, about 7%, 6.5%, yet about 12.5% of cases. Hispanic, Latin, 10% of residents, almost 30% of cases. Native Hawaiian, Pacific Islander, just under 1% of the King County residential population, yet about 2.5% of our cases. And this was, and should always be remembered, as one of the central elements to how COVID-19 moved through our community, and should have guided our response. We also recognized, as I mentioned, we started all this with no data. There were no protocols, no nothing. We really relied on our Ebola work to start doing this. But one of the key concepts that we did know work was this idea of the Swiss cheese model, which is used in various industries, including the airline industry. This is a great illustration by Ian McKay, a virologist in Australia, looking at the Swiss cheese model as pandemic defense. And one of the key things here is that it's a layer approach to COVID-19 prevention that's important. It's no one thing. It's not wearing an N95. It's not just distancing. It's not just ventilation. It's not just hand hygiene and similar. It's a lot of things. And if you layer all of those things up, as many things as possible, you can be extremely effective at preventing COVID-19 transmission in communities, in hospitals, and clinics. Some of them are personal responsibilities like distancing and wearing masks. Some are shared responsibilities like ventilation and information. One of the things that hit me pretty hard last year, and I think all of us, that I was not expecting, was this disinformation mouse that was nibbling away at some of these layers. The role of politics and disinformation or misinformation last year was incredibly hard for, I think it really impacted all of us. But as someone who's trying to do the right thing, to share the right message, to make policies and procedures that made sense, that would contribute to this Swiss cheese approach, to deal with disinformation at, how do we test, who do we test, what numbers there are masks good or bad, should schools be in place or not, made things so much harder. And I think that really impacted how COVID-19 played out, and ultimately contributed to the 500,000+ deaths we've seen in the United States as a result. We riffed on that Swiss cheese model with our infection prevention and control bundle. So this is looking at how we prevent COVID-19 within UW Medicine facilities. It's not just one thing, it's many things. Hand hygiene, distancing, testing, education, environmental cleaning. I would add, we need to add ventilation to this. This is how we keep healthcare workers safe, ranging from please stay home if you're sick, making sure exposed people are covered and paid for, PPE, testing of everyone, cleaning, and support and wellness. And I'd say this last part, I wasn't really paying attention to that until my colleagues, Trish Critic, who's a pulmonary critical care doc, and her team launched town halls very early on. So we started talking as a group to our community on every Friday and answering questions from the community. And that was incredibly helpful, I think. In retrospect, I wish we had launched earlier. We started getting some data on our approaches. This is a quick snapshot of a study done not by Harborview, but involved Harborview, where that middle group right there, what this looked at was looking at healthcare worker antibody positivity and then looking at community positivity. And you can see in some places, there was, like in New York City, high levels of community and healthcare worker antibody positivity, so have been exposed. Some places was disproportionate. The community had really high levels and health workers had low, and the other way around. This was very reassuring to me at Harborview Medical Center. We had lower healthcare worker antibody positivity, so folks who have been working with COVID-19 patients compared to the community, and our overall proportion was relatively low. And this, helped us a lot in understanding of how our approaches were working in terms of PPE and other parts of our toolkit, that Swiss cheese model, were working to keep people safe. So going forward, so I updated this chart. So there's our first surge, the summer surge, our huge winter surge. There was really a mix of the first two. We never got down really below 85. So our plateaus continue to rise and maybe what we look at in the future. And over the last couple of weeks, we've seen a brisk increase in cases. We went from a low of kind of mid-teens inpatient to now approaching 50 across our 4 hospitals. Fortunately, or unfortunately, it's mostly younger people, 20s, 30s, 40s, 50s, people who haven't been vaccinated. It is fantastic to see how these vaccines are working to prevent COVID-19, particularly in older adults. That skilled nursing facility population is not getting COVID, and they are not ending up in the hospital, and they're not dying as a result. But there's still a lot of unknowns going forward. There's the vaccine. There's what does it look like in a mixed population of unvaccinated and vaccinated people? What does it look like through breakthrough cases and similar? One of the big issues here we're struggling with are the variants. I'm not going to go through each of these, but there's a handful of variants of concern. What this means is these variants are different from wild type COVID-19 or SARS-CoV-2 in that they have mutations that have been shown in the lab, at least, to have certain properties associated with transmission or immune evasion. So just to give you a snapshot here, in the nomenclature is very, needlessly complicated, but I'm going to just defer to the location. So the UK strain 117, the Republic of South Africa strain, that's the 1351, the California strain, which is 1427, it's actually also 1429. There's a New York strain, the Brazil strain P1, and there's an Oregon isolate as well. And what each of these have, what makes them concerning, is that they have multiple mutations in the spike protein genes, which lead to various phenotypes. So you can see they all share this 614 and 501, which increase upper respiratory viral load, which you can imagine would lead to more transmission, and better binding on the ACE2 receptor in humans. Some of them have they generate more spike proteins as they develop in eukaryotic cells. Some are associated with neutralizing antibody escape in people who have recovered, so convalescent serum escape, and others have different mutations that are associated with other ways to better bind to the ACE2 receptor or have unknown impacts like the 1427. And the way this is rolled out here, this is from a week ago now, is that this orange are all the wild type variants, all the normal coronavirus. And you can see that there's been an introduction of the California strain in this kind of yellow mustard color, and then the UK strain 117 in this green color, to the point now that those two combined variants are now the majority variants. They're around 60% of all of the sequenced isolates by the UW Clinical Virology Lab are now those variants. And they're both associated with greater transmission. For the California strain, about 20% more transmission. For the 117, between 40 and 60% transmission. And potentially some worse disease in older adults. And the big concern here is that in Washington State, we've been largely successful in controlling COVID-19, which means most of the population is not immune and they're not vaccinated. And so when you have a more transmissible strain, a largely non-immune population, and more gatherings, relaxation of restrictions, i.e. phase 3, we're going to see more cases, and that's exactly what has happened. Fortunately, we are truly in this race with getting vaccines out to people. Right now in North America, we have the Moderna and Pfizer. We had the J&J, but that's on hold right now. The AstraZeneca is the one that's being used widely in the UK. The J&J and AstraZeneca are being investigated around some clots that are happening. But the Moderna and Pfizer are continue to be rolled out strongly. Obviously, they're a little bit harder. They're 2 doses versus the J&J, which is 1 dose. These are wildly effective vaccines. They far exceeded our hopes around their efficacy and effectiveness. They just shut down serious illness in COVID-19. They shut down hospitalizations and they shut down deaths. Doesn't mean there's none, in vaccinated groups, but remarkable decreases, in the 90+% groups. And they are also extremely effective, Moderna, Pfizer, and JJ, against all those variants I just mentioned. The AstraZeneca definitely has some challenges with the South Africa strain. And that study was discontinued because it wasn't working really well there. But you can see here that if you look at what was circulated in Latin America, that's the P1, 61% efficacy, the South Africa strain between 64 and in some cases up to 95%. So still incredibly effective against these variants of concern. So we really got to continue to push hard at getting people vaccinated in order to deal with that variant issue and obviously just the uptick in cases in different parts of the US. We're finding from real world studies now, beyond the studies they used to get the emergency use authorization, in various groups, healthcare workers, patients in different systems, huge studies coming out of Israel, 600,000 plus person studies, that these vaccines work as well in real life as they do in the studies. Incredible data showing massive decreases in infection rates, but also really important, decreased colonization or asymptomatic infection. And this is one of the things we've been waiting to hear. Can you be vaccinated, infected, and transmit and have no symptoms? What we're learning is these vaccines massively decrease asymptomatic infection. And also, even in the people who get breakthrough asymptomatic infections or breakthrough truly infections, the viral loads are very much decreased. They measure this through what are called cycle times, which is the number of PCR cycles it takes to detect SARS-CoV-2, that these are really, really effective at doing that. So they're going to not only decrease disease and death and hospitalizations, but they also appear to be extremely effective at preventing COVID-19 transmission. Here's various members of our team getting vaccinated. So Krista Riedberg, who you saw at the very, very beginning of that Seattle Times front page, Vanessa Markowitz, Allison Zelikoff, who's our employee health exposure manager. There's Chloe Bryson Kahn, again, from the home assessment team. That's me getting vaccinated. My wife was right next to me. This, I think, is Vanessa's mom getting vaccinated, which is pretty incredible. Very amazing to see this happening. And we just got to push it harder. But getting back to that graphic I showed you at the beginning with the trend lines and what's happening, the emotional toll of this epidemic on everyone, but I think health workers especially, is going to be long lasting. And we don't have good answers for this. This is my excellent colleague, Dr. Tim Delt, another infectious disease doctor, who's the CMO for UW Medicine. And on the right, that's Dr. Tuan Ong, who's a geriatrician and has been going into the fire, has been running into skilled nursing facilities since the very, very, very beginning of COVID-19, and has seen more disease and death than almost any of us. And the devastation, not only for the individuals, but their families, as these skilled nursing facilities, shut down visitation and similar. Incredible heroic work by him and his team. And this is the day he got vaccinated. And the emotional toll of getting vaccinated when other people didn't have access to vaccine really was hard. And you can just see it in his shoulders and in his spirit. And Tim, talking to him and talking him through how important it was for him to get vaccinated so he can continue to do the work that he was doing. But this is something we're going to be dealing with for a long time. So with that, I'm going to stop. There's your code word, infection. We have about a few minutes. I almost never stop early or even on time. So I'm going to stop there and see if there's any questions. I do, as fellow health workers, I just also want to say thank you for the work that you've done and continuing your important and critical care of patients throughout all of this. I know it's been hard. No one was spared. And for that, thanks. Back to you, Led.
John, thank you for that amazing story. Early on, you mentioned the WHO. I don't know if you're involved in a way that you could answer this question, but, during the previous administration, let's say, there was a lot of criticism of the WHO, how they handled this, and all kinds of innuendo that this started in a lab in Wuhan.
Yeah.
What's your take on any of the validity of that?
Yeah, so I just full disclosure, I work on a WHO committee on PPE, and I'll say a few things. So one, the WHO for the most part is composed of amazing people, their emergency response person, Mike Ryan, and his team have been absolutely stellar throughout all of this in providing clear, coherent messaging that has evolved over time. The WHO has to respond to a lot of things. So one is politics. They get paid, right? Their funding comes from countries, including China, and countries have to invite them in. They can't just walk into any place. And so they were working in a situation where they had very little information and no ability to go onto Wuhan and to assess and help, despite asking to do so. And so they were doing the best they could, I think, at that point. The other thing is when they build responses, they're building responses for the world. They're building responses for hospitals where there are, maybe 100 beds and 2 people per bed and no N95s, right? There's surgical masks that people reuse and maybe very limited gloves or limited hand hygiene access, or maybe no oxygen or an inability to isolate. And so it's this balance of how do you support healthcare workers, healthcare providers, healthcare systems everywhere in the world with a novel pandemic where the information, especially early on, was extremely limited. To this day, I think the most recent iteration I've seen of this that's come out from their most recent visit to China is that they still didn't get the access that they were looking for. They have no data that would support that this pathogen comes from a lab. We've had other pathogens like the first SARS that didn't come from a lab. Same thing with MERS, the Middle East Respiratory Syndrome, and others. We know that coronaviruses can do this easily. We know there are zoonotic infections. And to be honest, the first SARS is still out there. It just hasn't found another access point. And we're going to continue to see these issues. So, that's what I would say.
Well, we've got a big audience of a lot of smart people out there. We have other questions. He's left us some time here. Somebody.
Hi, John. This is Paul McBride. There's a couple of drugs that are coming through the pipeline, an antiviral pill called molnupiravir.
Yeah.
That supposedly can eradicate the infection in 5 days, and that's in phase 2 studies. Do you know anything about that?
Yeah, all I know are the mouse data. So, one of the things that we sacrificed last year, and this just has to do with our whole structure and our whole approach and our lack of funding, is and I'm not sure who we is really, but we decided to focus only on vaccines last year. No treatments. All the treatments we have basically were things we had on the shelf like remdesivir or drugs that we already had like steroids, hydroxychloroquine, colchicine, and many others, azithromycin, right? And so none of the drugs we have are actually that good. So we have no good treatments. The improved mortality, I would actually give credit to the healthcare workers who figured out things like proning and timing of oxygenation. But we didn't do anything around treatment, which is really, really unfortunate because that would have potentially saved a lot of lives. So the drug you mentioned, I can't pronounce it any better than you did, Paul, showed in mice complete eradication of the virus like in 5 days. So that would be fantastic to get a direct antiviral that's effective against SARS-CoV-2. So I'm hoping that and maybe some other therapeutics that might be in the pipeline are going to be available very soon. So I'm hopeful. The data looks great in mice. I'm waiting to see how it looks in humans.
Question?
Yeah.
Arthur Vague from Tacoma. So far, the immunity of what I've seen will last at least 6 months. Do you foresee booster doses or changes with repeat vaccination?
No, really important question. And the answer is, I don't know. So there's 2 ways to boost that we're thinking about boosters right now. One is you get the same vaccine again, right? So I got the Moderna. Would I need a 3rd Moderna vaccine like in the winter or something? So that's one. The second is, then the companies are working on this. Would I need a booster with a different spike protein, right? A different gene for one of the variants or more than one of the variants. So for the first one, we actually just don't know. Right now, we look at the duration of immunity, we're seeing in both people who recover, but also in people who are vaccinated, right? And the longest vaccines now are, probably that we have data on are probably 6 months plus. And we're showing that the immunity is quite durable, especially around or the things that are very easy to test, like antibodies, neutralizing antibodies, antibody titers. But you always have to remember that there are behind all that are the B and T cell responses that you guys know extremely well, that are, if you look in the lab, are showing really excellent responses that are probably going to be very long lasting. So this virus was first described, about a year and a half ago, and the vaccines about half a year. And so we're still learning a lot about durability of immunity, but the signs all look very promising that that durability is going to be fairly long lasting. And we won't know till we know whether we're going to need a booster. The part about the variants that's tricky is that there is some concern that going to be, once you sort of set your SARS-CoV-2 spike immune response down one direction, that there are some theoretical concerns about whether you can reset it or generate a novel response to different spike mutant in a way that allows you to respond to these variants. And so there's a lot to be learned about boosting for the variants versus, which is, I think, a pretty straightforward issue of boosting for what you've already taken.
John, why did the first two COVID diseases burn themselves out or not become pandemics, and this became one?
Well, I think that they are much more lethal. So, that one of the things we've definitely learned, and we don't know the actual percentages of this, is that, SARS-1, the first SARS, is quite dangerous. Even with that, with pretty much everyone becoming symptomatic, people, you're able to isolate people who are symptomatic and get them away from others. Same thing for MERS. Makes people quite ill, young and old apart together. And so again, you can isolate folks. Same thing. It's kind of like the idea of measles and polio and similar. The issue with asymptomatic SARS-CoV-2 is that you don't know who's infected. And so you can't actually isolate those folks. And they can go on and transmit from, you could have no symptoms, mild symptoms to quite severe. And there's also a very clear super spreading phenomena that we don't fully understand, why some people transmit tons of SARS-CoV-2 and others don't. So I would say those are some broad.
John, a question on long-term consequences, people that have had severe COVID, people that have been on ventilators. What's happening with development of pulmonary fibrosis, or the people who've had renal dysfunction, or the people, the long haulers with mental problems, psychoses, and
yeah. So I don't know as much about the sort of bedside stuff, Bill. It's a great question. We definitely have had people developing, pulmonary fibrosis persistently. I think you probably all know that we've had at least one lung transplant, bilateral lung transplant, someone as a result of that. I know a little bit more about just the long hauler stuff. So this is actually, again, comes from Helen Chu, who did that Seattle flu study in those early diagnoses of SARS-CoV-2 in our community. She published a paper recently showing that about 30% of people with symptomatic COVID-19 have persistent symptoms months and months out, which is much, much larger than we anticipated. And I still think we have a lot to learn about this. It's called a variety of different things. I think it's called PASS-C by the NIH. I think long haulers is what most people think about. But it's going to be interesting to think about diseases like COVID-19 with persisting symptoms, other diseases, other infectious diseases like borreliosis that have persistent symptoms after resolution of the, eradication of the pathogen. And how they maybe twist and turn the immune response to lead to these persisting symptoms. So I don't know much, Bill, beyond just that information. There are clinics that are coming up. I know here at Harborview in our rehab clinic, a guy named Dr. Aaron Bunnell, who's a rehab physician, is working on this and has a whole clinic. It sounds like it's very busy with people who have recovered from the acute illness but have persisting symptoms.
John, how have you held up through this past year?
Well, I mean, I've held up like a lot of folks, it's been an unhealthy year that I'm trying to recover from, sort of putting off personal things like my family. My health has been hard, and I'm in sort of recovery phase. I am incredibly fortunate, and that's why I highlighted a lot of those people at the very beginning. You know, Chloe, Vanessa, our team here, the larger UW Medicine response, ranging from Tuan Ong and Allison Roxby healthcare facilities, to, you know, Mark Taylor, our incident commander here at Harborview, Santiago Neme, and Nandita Mani, and Seth Cohen, and other infectious disease docs. Just a huge team of incredibly dedicated and skillful and highly intelligent people who have responded to all this and worked together. And so it's going to be, you know, this whole kind of recovery phase is going to be interesting. But my goal this year is to spend more time with my family, look a little bit after my health, and try to keep this ball rolling so we can keep everyone safe.
Well, thank you for a fascinating morning. I hope next year when you speak, it doesn't have to be on this topic. Or if
Anything else besides COVID-19, please.
That's the end of the pandemic.
Yeah.
All right, stay well.
Thanks. You too, everyone.
Bye-bye.
Thank you.